Hello everyone, welcome to the concluding session on expositors and boosters. And in this session, I will discuss the questions which were given during session 20, Viva questions and homework. Question 1 was, would you like to continue oral iron therapy along with IV iron? The answer you must have found out, and the answer is oral iron should not be given with concurrent use of intravenous iron sucrose. Combined treatment with oral and IV iron may lead to appearance of highly toxic non-transferrin bound iron in the body, in blood, and it is recommended that oral iron preparations are discontinued at least 48 hours prior to IV iron infusions. Question 2. IV iron preparation which will interfere with MRI imaging. Question was, which preparation is there? The answer is newest, latest one is ferrimoxitol, and it interferes with MRI imaging because it contains super paramagnetic iron oxide. Question 3. Which oral iron salt contains maximum amount of elemental iron? The answer is colloidal ferric hydroxide liquid contains 50% of the elemental iron. However, it does not. This is the best preparation to be used. All iron preparations shown here have amount of elemental iron that can be absorbed, and as we know that a maximum 25 to 50 milligram elemental iron is absorbed irrespective of what salt is used, because the irrespective of the iron content, only 20 to 25% maximum is absorbed in anemia. Another question was, how do you assess effectiveness of oral iron therapy clinically? Now, it is found that an increase in reticulocyte is not observed for at least 4 to 7 days after beginning of therapy, despite rise in the serum iron levels. Rise in hemoglobin takes even longer. A decision regarding effectiveness of treatment should not be made for 4 weeks after the start of treatment. An increase in hemoglobin by 2 gram deciliter or more in 4 weeks of period of time is considered to be a positive response. If it does not occur, then oral iron therapy should be stopped. Now, based on this, MCQ 7 is the earliest indicator of response to iron therapy is, and the answer is rise in reticulocyte count. Other parameters rise but late. Homework given was question 1, enlist 3 pharmacological characteristics of myodron, and you will see that there are pharmacokinetic and pharmacodynamic characteristics. Pharmacodynamic characteristics, it is a multiple cardiac ion channel blocker, but predominant effect is on the delayed rectifier potassium current, thereby prolonging action potential duration. Pharmacokinetic characteristics, it is a drug with very long half-life of almost 80 days, large volume of distribution, concentration and accumulation in tissues with slow release, and that causes tissue deposition and adverse effects which are delayed, such as corneal microdeposits, pulmonary fibrosis, hepatotoxicity, peripheral neuropathy. One of the characteristic feature of myodron is thyroid dysfunction. It causes hypothyroidism more frequently than hyperthyroidism, and this is because of it is derivative of thyroxine having 37% of the iodine, that is 75 milligram in 200 milligram of tablet. So it will naturally, iodine content will alter the thyroid function. And another characteristic is no dose adjustment is required in renal failure, because non-renal elimination is the predominant route. Now, question 2 was three characteristics. What are the three characteristics of cilnidipine? Cilnidipine is also having peculiarities, but they are mainly pharmacodynamic. It is a dual inhibitor of voltage-gated L-type of the calcium channels in cardiovascular system and N-type of the calcium channels in the sympathetic nerve endings and the renal endings that renal sympathetic ending also. This drug has shown cardioprotective and renoprotective action predominantly due to reduced sympathetic activity and reduced generation of angiotensin II indirectly. Neuroprotection has also been shown. Its renoprotective action is seen in patients who have hypertensive renal disease, and it reduces proteinuria. Another question was, why do we give oral loading dose of chloroquine, an age-old drug for malaria? There are pharmacokinetic characteristics of this drug. Oral absorption is nearly complete, so it is the oral route that can be used. Extensive tissue distribution like amiodarone, very high volume of distribution actually, unexpected high, and concentration in liver, spleen, kidney, and infected blood cells, red cells actually, white cells also. It has a long half-life of almost 24 hours with terminal half-life much longer than 24 days. Chloroquine oral dose is therefore needed to achieve a desired blood concentration, and it decreases the time to achieve 50% reduction in the parasite load in the blood. If we do not give loading dose, this beneficial effect will be lost. Question 4. Amiodarone requires oral loading dose. That is the answer for another question. Which other drug? There are many drugs. One of them is amiodarone. Now again, it has a characteristic of slow accumulation in tissue. A high oral loading dose is given that is protracted for several weeks actually before maintenance dose is. One PG question was, which is the key regulator of iron hemopoiesis? Whether it is hepcidin or ferritin. Details of these two key components for iron homeostasis, we will compare and find out what is what. Hepcidin is a hormone considered to be hormonal polypeptide from liver, and that regulates the iron transport during absorption and release from the storage sites. It does so by binding with ferroportin that normally is involved in basolateral transport of iron from the enterocyte. Therefore, as we all know, there is no excretory mechanism of iron in urine. Therefore, and iron is very tightly conserved, and therefore its needs are regulated at the level of absorption and distribution by characteristic involvement of certain protein compounds. One of them is polypeptide regulator of iron transport, the hepcidin. Now, in iron deficient anemia, hepcidin levels are decreased so that more transport occurs through ferroportin across basolateral membrane. So there is an inverse relationship between level of hemoglobin and iron and hepcidin release. Anemia of chronic inflammatory disorders is characterized by many features. One of them is increased levels of hepcidin. And in hemochromatosis, where there is excess iron deposit, there is a marked decrease in the level of hepcidin. Is a body defense mechanism to avoid the iron toxicity. However, it fails that way. Compared to this, ferritin is an ferritin synthesized in mucosa that can freely bind with the free ferrous form of iron and stores it in the ferric form. And in this, if there are aggregates formed, it is called as hemocyte in tissue. Now, ferritin is an iron storage protein. It sequesters free iron to prevent toxicity of free iron, and therefore it is involved as a sequester, protective, and forms a protective iron curtain, and is also a transporter of iron to some extent, although transferrin is the main transporter. Now, its levels correlate with iron content. Therefore, we estimate ferritin to find out the stores of the iron in body, and naturally iron stores are decreased in iron deficiency anemia, so ferritin levels are also decreased. Ferritin levels are increased in inflammation. It is actually acute phase reactant also, and its levels are elevated in hemochromatosis. Unlike hepcidin, levels are decreased. So we compare that both are the key factors, but the main regulator is the hepcidin. Another question for postgraduates was, what is the rationale behind giving oral ferrous sulfate as a single dose daily in place of 2 to 3 doses? Currently, it is understood that therapy with single dose of 325 milligram has an equal efficacy as compared to 325 milligram 3 times dose. This is one. And this is because 25 to 50 milligram or a maximum 100 milligram of the elemental iron is available for absorption and hemophysis. Now, the main reason is that if we give 3 times daily, then there is a continuous production of hepcidin in response to increasing iron levels, and this will reduce the transport of iron in the blood from the basolateral membrane when we give multiple dosing. Therefore, actual effect will be decreasing rather than increasing when we give 3 doses. And second reason is it is better tolerated. Once daily has a better adherence and compliance, and less GIT effects are there. Patient's tolerance and acceptability is more. And this is probably the reason why even UK guidelines say it is better to give once daily doses. References are there. NHS iron deficiency anemia guidelines are there, which can be accessed and find out. This completes with the series of spotters and boosters, and I shall start with a newer series, vignettes and pearls of pharmacology. Stay with us.